All right. So let us begin. So this is the starting point. So I'm planning to do this, finish this, which won't take terribly long, and then this, which we will start. So the male and female reproductive. The long one by far is probably going to be last week at this time, which is going to be the female reproductive physiology is fairly complicated. Male is relatively simplistic. The anatomy in both I don't think is overwhelming at all. So this is the second part of the urinary system, and I every time I do it, I learn a little bit of something. So, see, and this is just sort of talking a little bit more about it's almost where I left off. This is kind of what happens. We have three events, and this is sort of reiterating something I commented on before. We have the actual act of filtration. We have then this reabsorption that occurs, and I did this before, and it occurs. It doesn't matter to us. Basically, we reclaim 99% of this magical filtrate we create 180 liters of, 40, 45 gallons of every day. And we suck it all back in. But in the process of doing that, we're selectively leaving in stuff in there to secrete. We're even sucking stuff back in that we're going to kick back out again so we can create concentration gradients. In the meantime, balancing out the water and balancing out the pH, et cetera, et cetera. And you can go through the cells or around the cells. That's all that means. I know I did these slides, and it's it has to do with, and this is more what we do in the advanced physiology class to understand the particular routes for certain substances like calcium and magnesium, et cetera. Not a big deal for us. The big player is certainly sodium, because sodium, wherever sodium moves in whatever direction, water goes along with it. That's the key. And in general, the other rule is if sodium is going in one direction, potassium is going in the other direction. And that's the kind of stuff that you'll encounter with certain medications that people have. Sodium, we regulate our sodium pretty good. Potassium's scary if that starts to drop. That's a bad thing. So potassium and calcium, those positively charged particles, not so much the sodium, because there's so much of it, it plays such a role in water, but that's something to be, if you're in a situation where you get a medical chart, take a gander at the blood test. They're going to be on there. Sodium and potassium, in the old days it was all, I'm sure it's all digital now. I often imagine what it would be like to go back into practice with all the technology. That's why I think you see so many medical practices are now basically under the wing of a particular hospital health system. They're part of UPMC or AHN. The cost of the technology alone has got to be having all the computer support, all the billing has. It was in its infancy when we started. I got my first computer for an office in 1985, so I try to be ahead of the learning curve. But I mean, we were using an old, are you ready? A dial-up modem. You have no idea what I'm talking about. Oh, it's like you have one of these, you push, at least have push buttons. It wasn't, If you can find one of those in a thrift store that's real, grab it. People will pay a ton for it. Always on the lookout. So you dial it up, you hear your tone, you put it into like a cradle, and it would beep, and that would connect you to the other computer. And then it would be just tones. I mean, the speed that you have on your phone is 1,000, probably more than 1,000 times faster. See? Little history. So sodium is a big player. And I did this before, but I think it's important because sodium moves so much and other stuff moves with it, like water. And so when you're moving sodium in water, it's creating current flows. Just like you're in waves and things like that. If you're swimming in a pool, and you can either move stuff along with it, like drafting that usually swimmers do in a pool if they're racing, you see it in the Olympics all the time, or you'll have the rebound effect when the water rushes into the shore, it hits and it comes back out like the waves we have in the Atlantic, particularly the undertow, and it pulls stuff out, and it pulls stuff out along with it. So you have co-transport moving with the current, the flow, and anti-transport using it sort of backing up in a reverse because just the passageway is open. And so that's what they're talking about. Primary is moving the sodium, let's say, we expend the energy. And secondary means using that as a push, for lack of a better term. And it's a good term here. And you see all the important stuff that moves with it, glucose, the stuff you want to retain, vitamins. And then other places where we lose water or gain water, whether we're going to retain it or not, has to, and we see this mostly in those collecting ducts or in the distal convoluted tubule where we have things. So in the proximal convoluted tubule, water is easy to move, but other places it's not. And so you have antidiuretic hormone and aldosterone. Basically, the way they work, they insert little passageways, protein passageways, that the water will go through if it's antidiuretic hormone, or aldosterone will basically design to bring sodium and then water follows along with it. As I'll say 58,000 times, Stein's Mary had a little lamb rule. Where sodium goes, water is sure to follow. I used to get a better response. Try to be humorous. Nobody thinks you're. Transport maximums. I made a big deal of it. I'm going to make a big deal of it again. The big problem we have with diabetics, why the whole idea, I'm sure I covered it with diabetes, is we can really pull back about 180 milligrams percent, meaning that concentration of diabetes. We have that many openings that sugar can attach to reclaim it. Diabetics, if they're out of control and over that number, it saturates them. It's called the transport maximum. When there's, not only will it not pull the sugar with it, it damages the transporters when they're completely used up. And so the longer they're used up, the lower, the less it lessens their ability to transport. So let's say for a month they're at maximum. Now the ability now is no longer 180, it's 172. And then another 3 months, maybe it's 168. And you get the idea. That's why, if you, and everybody knows somebody who's a diabetic, everybody knows somebody who takes pills or takes insulin, why it's so important for them to be controlled. Aggressive control is what prevents long-term complications like kidney failure and having to have to do kidney transplants, avoiding them being on dialysis, losing limbs, heart attacks. You can't, it's the single most important disease still when you're dealing with certainly an older population. And certain ethnicities have a higher percentage of it. Just throwing it out there. So, and that's why we used, before we had those neat little finger stick things that everybody uses today, glucometers, and you can go into Giant Eagle now and get one that works great, saves the data, all that stuff. You can chip it into your computer. It doesn't matter. People used to dipstick their urine, and they collect it and they get it. They flow just the way you would do an early pregnancy test, or for a man it would be easier, perhaps. That type of thing. You just measure it and you get a color change, and it would tell you +1, +2, +3, and they cover it with insulin. That was the old way they would do it. Now you do it with a glucometer. Oh, you're reading +1, it's a little high. You better take 3 units of whatever insulin you're taking. Different world, but that's the way it works. So most of it's in the proximal convoluted tubule, even though, as you can see with urea, we're going to get rid of it, most of it, but that's going to help create a concentration gradient. We'll look at the loop. When the loop goes down, the thin portion, water moves easy. When it goes up, it's thick. Solutes move, and they have to keep in balance. And that's what we're coming. Here's the antidiuretic hormone. And I did this all before. That's why I'm buzzing through this. Aldosterone, etc. These things. They just show it to you. And in secretion is just, rather than pulling it back in, just getting rid of it. Again, it's nearly complete in the proximal tubule. After that, it's very selective. These are stuff we want to get rid of. Potassium, hydrogen ions, ammonium, creatinine, all sorts of stuff. And again, there's a good news, bad news that I skipped over. Some things are reabsorbed that we don't want to be reabsorbed, certain toxins and things like that. So there's certain stuff that stays with your body longer that we have to be very, very wary of. Okay? So all of these types of things, and that's the way we control pH and etc. and things like that. Huh? Oh. Messages. So this is where I left it off. Osmolarity. Our bloodstream. It's the reason we use normal saline. It's the reason we use lactated ringers. Those are osmolar, what we call isotonic media. meaning you have this, and it doesn't matter what the particle is. It can be salt, sugar, or a mixture. It's how many particles per how much fluid. So pure water will be great to drink, okay? But the problem is that overhydration. It was just a case where somebody died from having when they drank too much water, inadvertently or in a medical situation. I don't know what it was. So you at that point you can overhydrate. Now the water pushes in and begins to damage cells, and someone can die. Okay, so that's why it's so important to keep this in balance, because all the other fluids are based on that. We have to get rid of enough stuff to make sure that we always have the right proportions of solutes, all the stuff dissolved in water, glucose, amino acids, proteins, electrolytes, to water. And so that's where they go, and that's the difference between what's called osmolality and osmolarity. And osmolality is about weight, osmolarity is about volume, and I don't care. So, why do the kidneys only produce a small amount of urine or dilute urine? So, if it's dehydrated, you retain the fluid. If it's overly hydrated, you get rid of it. Okay, and this is this countercurrent mechanism, and there's two of them. And it has to do with those long loops. The short loops don't really play with it. They're more about reabsorbing and getting rid of charged particles and other chemicals. So it has to do with it flows down, the water leaves, and when it comes back up, the solutes leave. And because you're getting movement of water out one way, salts out the other way, you have to flip-flop them in such a way, because if you'll have an overabundance of water in one place and an overabundance of solutes in another place, so you have to exchange them, and that has to do with the blood supply, those long vasorecta that are sort of draped over those very long loops. So we're around 300 normally, is sort of the magic number, and in the cortex of the kidney, the outer area where the glomeruli are located, that's what it is. But when you get down to the tip of the medulla, all the way down to the bottom of the loop, it's 4 times as great. And that starts developing when we're born. And over a period of time, it's 300 all the way through. So there's no real way to concentrate urine. So if you babysat, you know how often you have to change diapers. Okay? If you have little kids, you know it's just ridiculous. They're wet again. Great, change them. 3 kids in 3.5 years. 3 years and 2 weeks. And they were all adopted. What were you thinking? So what happens is, over time, basically the gradient it's rather complex how it establishes it. But as you begin to do the exchange, the numbers, because there's always about a 200 difference between one level and the next. And they'll show it to you. So this is what it looks like. Out here, normal. Down here at the tip, very concentrated. Okay? Same deal here. Normal, down to tip, very concentrated. Here's, in the long loops, here's the thin segment. This is where the water moves out. Here's the thick segment. This is where the solutes move out, rather, up here. Okay? And so it's all about them. The blood vessels, and it's all about this hairpin turn for both the loop and the blood vessels. They do the exchange. So it involves the loop. Filtrate flows in opposite directions, first down then up. Water can move out of the thin area, solutes only in the thick area. They're not in contact, but close enough to influence each other's exchanges. So the differences between the concentration levels impact one another from proximity. They don't have to touch, but close enough. So in the ascending limb, water can't move, but sodium and chloride are actively resorbed, so even passively resorbed. Descending limb is all about the water, etc., etc. So the more the salt in the ascending limb actively transports, the more water in the descending limb. So they work in concert with one another. So as the water moves out, it becomes saltier, and then the ascending limb gets rid of the salt. That's great, but we have to, in order to keep it going in that direction, you have to exchange. You have to get rid of the stuff, or basically to keep that relationship set all the way. So, always exists between the two limbs, between of the nephron loop and between the ascending limb and the interstitial fluid. And they go through a whole pattern of how this effectively becomes created. And you can see it here a little bit. Water moving out as it descends, salt moving out as it ascends. And you can see that's what I mean about there's a subtle difference of a couple of hundred, particularly when you get up to areas like here. So it's a little, when you get down to the bottom, as the water moves out, more concentrated as you get to the bottom than as it ascends, where it's less concentrated, as you can see. So roughly it's about a 200 different, not consistently, but roughly. And so the exchanger is what happens after that. Again, the blood vessels, the vasa recta, the capillary bed, they'll suck up the water in the solutes, no problem. It's also counter current, okay? They run next to each other in the same direction, parallel, okay? And what happens, it reabsorbs water and solute without undoing that concentration relationship. So it preserves it, okay? So the countercurrent exchanger preserves it by preventing the excessively rapid removal of salt and still removing the amount of water that's necessary. That's there. And that's all. That's really all what it's all about without getting into it excessively. But those mechanisms are really important. So the multiplier is sort of what creates the gradient and allows, to summarize it, and allows us to to really concentrate the urine. We can pull out a substantial amount of water and balance it out to make sure we get rid of a sufficient amount of salt. In order to continue doing that, the exchanger plays a role by picking up the water and picking up the salt and returning it back to the general circulation. And that's why by the time that vasa recta, by the time they get back to the veins that are surrounding the nephron, not the nephron loop, but the distal convoluted tubule, and then eventually back into the veins going out of the kidney, now effectively that blood is no longer thick and dense and just barely flowing. Because once the blood exits by, if you remember that it goes in by the afferent arteriole and it leaves by the efferent, that arterial blood is really thick. And by the time all those capillary beds do their thing, those loops, by the time it works its way down the loop and up the loop, the venous blood, and heads back to the veins that are leaving the kidney, now it's back to normal. Except it's gotten rid of impurities and it's got the right balance of solutes to solvent. That's sort of the summary statement. So, and we all see this. If you're on a hot day and you're working out or you haven't been drinking a lot, you don't need to go. Okay? Without putting too fine a point on it. And if you're relatively speaking, if you're having a lot to drink, it doesn't necessarily have to be alcoholic or otherwise, but just a lot of fluid. It's just sort of natural the way that works. Some people do it intentionally. I don't know. I see some people drink what I think is much more water than I would drink. My stepson does that when he's working around the house for us. I mean, he's a 32-year-old man, but I mean, he's just drinking water like crazy. Okay. Right. So dehydration produces small volume of concentrated urine. So, and it's maximally concentrated 4 times normal. And even and a great deal is absorbed. And so that's kind of what they're talking about here. Whether you're exercising, and it's so much different. And kind of why, just because the desert reminds me, why it's so important if you're going into an area, whether you're camping or hiking or just going exploring, make sure you have water with you. Because that's the time you don't want your car to break down. We went out to Joshua Tree. We're up in Palm Springs. It's 110 degrees. We're in the summer. Every day. And then we went to the Joshua Tree National Park, which is a desert. I mean, it's very scenic. I mean, my wife's second oldest son, who was with us, is a geologist. I mean, He said, if we don't each have a gallon of water in the car for each of the half dozen or so of us, we are not going. Period. We're running over to Walmart filling up water bottles. He says, you're nuts. He's right. For some reason, we like it hot out there. Don't know why, but we do. The kids would play at midnight. They'd be in the pool, which was open all night, and be playing volleyball in the pool. It was like 99 degrees. With some other beverages that were being consumed. Don't want to discuss those with you because I know that would be inappropriate. Nobody cares. So, and they're talking about the gradients that are there, which brings us more to the medically or the clinical part. Chemicals that can either enhance or retard that. Okay, so the most famous of them all is alcohol. It inhibits antidiuretic. That's why alcohol isn't good for a lot of things. It increases it slows your ability to clot blood. Okay, obviously it has a when you have a lot of alcohol becomes very toxic levels are relatively easily achievable. But this is a big player with this, and that's why we didn't use it a lot for people for surgery or sedation because it really impacts a lot of other things, and particularly this plays a role. It doesn't allow antidiuretic hormone to work. Sodium resorption inhibitors, okay, and therefore the water doesn't come in. Caffeine or drugs for hypertension or edema. They are there are drugs that can do that, and they'll block caffeine. Okay, and a lot of times people we used to use these kinds of things a lot, particularly loop diuretics that don't allow that gradient to form. The problem with and that was the go-to for treating people's high blood pressure. They still use them a lot in the hospital because a lot of the people have catheters, and you're able to collect and monitor the urine more easily, so you're able to see if they're being hydrated or not. They measure something called INO, input and output. So, but the difficulty with giving them to you and I in the workplace, even though that changes in time, people have to go all the time. Okay? And it's, you could be sitting in a classroom for a half an hour, and all of a sudden, you couldn't be there for 40 minutes or whatever it was, even if you didn't have a lot to drink. Even though that effect kind of over time softens a little bit, your body gets a little more used to it. Okay. So osmotic diuretics, that's the classic diabetic. The sugar pulls water along with it to balance it out. So, and that's why that's why they call it the great thirst. Polydipsia means you urinate a lot. So the urine is a great test because it's a quick snapshot to see if everything's working appropriately vis-a-vis blood pressure, chemicals, because it's reflected very easily and it's non-invasive. You don't have to stick somebody to do it ordinarily. You don't have to do anything invasive to do so. So if you really want to get it, and obviously the illegal substances thing is a whole different matter. Be aware of that. Words of the wise stuff. It's more. There's a lot of workplaces that are mandatory for things like that. If you're not aware of it now, you certainly should be. Okay, all those things. Like I said, my one is texting me. I mean, he drives commercially as a hazmat for hazardous materials and things like that. The first thing that happens, if there's an accident, a lady rammed him from the back. Thankfully, no damage to anybody. Before he could go into the truck again, they had to have someone take him to the hospital to get a blood test, a urine test. First thing, government rule. It's under the ordinance. It's under the TSA, Transport Safety Administration. That's what happened. First thing when he gets a job offer, you have 24 hours to go and get tested. A lot of places that's mandatory. The whole drug-free workplace, which didn't used to be the case. So you need to be aware. I'm not judgmental about things like that. I am not. I don't know how they relate these days to the recreational usage of marijuana and marijuana derivatives, the THC and the cannabinoids and all that stuff. I don't know the CBD and THC. So I mean, I haven't used that stuff in 50 years. So I did. 50 years ago, the statute of limitations is expired. I was in college during the Woodstock era. Is that a famous rock concert? Told you, we didn't have to go on spring break. You could just take whatever substance is and put up a poster, and you could look at that periodic table. You can go almost anywhere. It was album covers were a big thing. Music came in vinyl discs that were, you've heard of that. It wasn't here. Moving on. So, and I showed you this before we looked at my blood test. If you can estimate it from blood tests, and you can certainly estimate it with a combination of urine. And the big player is right here, nitrogenous wastes. Okay? That's when we look at creatinine and BUN, blood urea nitrogen, big players, and you can determine snapshot if it's actual renal clearance. How rapidly to determine a thing called GFR or glomerular. That's the criteria as to whether or not your kidneys work or have failed. Okay? And that also gives you an idea if they're not working properly, is there damage, or you're looking to see if you are known to have some type of disease in the kidney, what's it doing? And there's a whole way of calculating it. In the old days, I talked about this a little bit in the dictation I recorded. They'd use this. It's a polysaccharide, not going to harm you. It's just that we don't break it down or use it or absorb it. So you get a certain amount, and you should clear that exact amounts. It's either, so there's ways to look at it, but the whole idea is that no net reabsorption or secretion. That's how they figure out that GFR. This is something that whatever you take in, you should completely take out. And the way they used to do it to get that number was do something called 24-hour urines. They give you a dose and they collect your urine for the next 24 hours and measure it. And it's still done for certain things. But unlike a pregnancy test, there's just not a high enough amount to be able to get an idea of what the number is from a dipstick technique or some other technique. It just doesn't work, not as effectively. And so if someone goes under 60, at that point, they've got chronic, means it's not going to get better. Okay? You can't make as much filtrate, wastes accumulate, all sorts of problems. And we see this particularly, and there's an interrelationship. Because diabetes, very much autoimmune antibodies are produced in a lot of diabetes that precipitate or form in the kidneys and create problems in the kidneys. When it goes that low, okay, under 15, that's kidneys are done. And then this is really nasty. And the only thing you can do is transplant or have the person go on dialysis. Years ago, if someone went on dialysis, they could live for maybe 5 to 7 years. Now it's much, much longer. You had to put in a artificial port, a shunt that they could keep, and that had a limitation how long. Now they last quite a bit longer with that. And dialysis is very. My first wife worked for a year as a dialysis nurse in Philadelphia, but after we had gotten married and before we moved back to this neck of the woods. All those things. So I became rather familiar with the saga of all of those things. So, and I saw it up close because my grandfather, his kidneys failed. He had lost a kidney due to disease when he was relatively young, like say 50s or 60s, and succumbed to renal failure when he was 86. And he had, uremia is very interesting. So if you have a patient who has kidney problems and all of a sudden they're scratching all over the place, when that uremic poisoning gets into your system, you get very itchy. Plus, there's some very unusual behaviors. They start to really, it's almost things inappropriately funny, and doing things that they never did before. That's kind of what you watch for with older relatives sometimes. The mental changes, particularly, that were there. And we noticed that a little bit with him. Uh, So, and it's mostly water with some solutes. The big players here are the nitrogen, urea, uric acid, creatinine that are there, and other stuff that's in there as well. And so and again, we look for that. That's what, when you do a urinalysis, not only do you dipstick it, but you do it microscopic to be able to say, you take a little bit and look on, stain it and look underneath. Do you see white cells or red cells? Do you see anything else that's there? Uric acid will have little crystals. Proteins will form something called casts. And they are all in, if they're not supposed to be there, if they're there, you got to figure out why they're there. Sometimes it's easy to figure it out. If someone is recently, if a woman's recently had her period, finding a touch of blood is not going to, nobody's going to go crazy over it. Okay. Or maybe there's a minor start of a urinary tract infection. So the matter of degree does that. Same thing with bacteria. We often get specimens from women that are not likely as, and it's not, it's just harder to do what's called a clean catch. So if you see back, then typically we'll take that and culture it to see if it's just a trace of bacteria or whether there's a sample, a sufficient number. And often that's the case, because if it's a high number now, that's more consistent with infection, should be treated. Some in substance. And this is, you can go through this. Again, it's related to the hemoglobin breakdown and the bilirubin, eventually becomes something called urochrome. Different things cause different problems. And again, seeing discoloration often is significant of blood. Seeing red means a lot of blood, and that's a bad sign. That's me. That was the big indicator to me why I had bladder cancer. You start to pee red. Scary. And all the stuff, yeah, the smell, the pH. And these are all things they measure typically when you do a urine sample. The rest of this is there's not a whole lot to say about this. This is all, the urinary tract is nothing more than two tubes that carry urine. Don't do anything to it. There's some peristaltic action that's there, and they go basically into the undersurface, so to speak, and they're retroperitoneal. They're on the back wall, so they're not floating around in the abdominal cavity. They go through the back wall, posterior wall, and the urethra forms very, very close to it and exits. Okay, when your bladder fills, the pressure prevents it from going back up. If it goes back up, that's a whole different subset of problems. It's a triple layer. The lining, this is very significant, and I say it all the time. You always get questions on stuff that affects. My cancer was a TEP, transitional epithelial cancer. Thankfully, in a very, very early stage. Thank you for 40 years of smoking cigarettes, which none of you could possibly do, because you're not 40. I'm not even sure if you're 40 aggregate. So it has a rather substantial amount of smooth muscle. The smooth muscle's got a famous name. It's called the detrusor. You'll see that. And really, that's the bladder. I'm talking about the ureters. So smooth muscle here, again, stretch, acts of peristalsis similarly. Sympathetic slows it down. Parasympathetic increases it. Retroperitoneal has adventitia. Nothing special. And you see, it's got the ability to expand, and when it's empty, it contracts. The trouble is these little areas here and here, if crystals form in there, that's where stones, and then it can't expand or contract, it irritates, and the muscle goes into spasm. That's what we call urethral, URETRAL, colic. That's why kidney stones are so painful. Colic just means spasm, a colicky baby, digestively spasms. So they're called renal calculi, calcium, magnesium, blood, uric acid, bacteria, all can be the core. The pain, by all accounts, is excruciating. It has become more common. It used to be almost always men, usually like 30 to 50, that aspect of things. Now we're seeing, you see a lot more with women and younger women. There's been more dietary calcium. Sometimes they eat the wrong kind of calcium, more urinary tract infections. A cousin of mine, when she's similar in age to me now, I remember she had a tremendous problem. They had to do lithotripsy, where they have to shoot the sound waves at it. She was a mess. And there's different kinds where they lodge. Most of them pass fairly easily. The sound wave therapy has been around for a long time. It's a lot of the reason why you should hydrate. I should keep reading this because I don't. The bladder itself, this is the other transitional epithelial I'll talk about in a second. Retroperitoneal. The difference is location, and we'll get to that when we look at the anatomy because it's part of male and female reproductive anatomy. In males, the prostate is immediately surrounds the exit point of the ureter, and it's important we really look at it more closely in repro and A and P. Whereas the females, it's slightly anterior to the vagina and the uterus and parallels it, but in relatively close proximity. That's the problem. So that's a lot of the problem we deal with the microbiological aspects. And for many of you who unfortunately have chosen to have me for micro, and I have no idea why. You should have your heads collectively examined. I would have picked anybody else. And so, but we take a look at the impact is anatomical. It's another one of these anatomical bases of disease that I've always fascinated by. So this area, when it's empty, it forms those folds like the stomach. They're same name, rugae, little ridged areas. When it's filled, the muscle expands, they flatten out. This area called the trigone is always flat. And there's not a lot of movement, and that's where infections in the bladder start. The muscle is the detrusor. Transitional epithelia looks like stratified squamous, but it doesn't keratinize, and the tops aren't flat because that's what squamous is. The top's sort of rounded. It's really a misnomer. You have 7 to 12 layers. When the bladder's empty, you can see them. The top's on the outermost layer around it. When the bladder's full, they squish down to 2 or 3. The layers are still there. It appears transitional. It's an optical illusion. And here they're showing you this trigonal area. And in the male, it's external. It's away from the anogenital area. It's a totally different bit of anatomy. And again, we'll explore all of this in the male. In the female, much shorter, and shorter is bad because infections from the outside get in more quickly. So you have maybe 3 to 4 times as much length to traverse, and it facilitates the infection. So again, it's anatomical. And here's the trigonal area in here. The detrusor is the big player. When I had this cancer rather, the key is, does it get into the muscle? As long as it was confined to the lining and didn't penetrate very much into deeper areas, just barely in my case, did it penetrate into the underlayer of it. Okay, if it had been in the muscle, whole different. The treatment would have been a whole lot more sophisticated. So it collapses when empty and the rugae appear. So moderately full can hold about a pint, but more than that. And what they do in the hospital, maybe you've seen people have them or have had one done yourself. If you empty your bladder, they often do, particularly for inpatients, do a urogram, which is an ultrasound that gives you a quick measurement of what's left in there. This is called an IVP or intravenous pyelogram in the old days. Different study now. We used to inject people with an iodine-based dye, and it would outline the kidneys and the ureter and the bladder. This is probably a more sophisticated stand. But so we have different technology for it. But you'd use that to see if there was anything in there, a tumor, irregularity, et cetera, et cetera. And then the urethra itself. And we'll get, again, more into that. The transition, the bladder and the ureters are transitional. And then all of a sudden, as it gets near the bladder, it's transitional. But the urethra is mostly stratified squamous as it gets near the end. It starts to change from transitional to columnar. And then as you get near the exit point, stratified squamous. And there's sphincters to control it, et cetera there. And we'll go over the parts in the male. We don't have this in the female. It's just there, and you have an opening for the outside. In the male, the part that goes through the prostate is called prostatic. There's a membrane from when the urethra goes from inside the abdominal pelvic cavity to outside. That's the intermediate or membranous part as it goes through what's called the urogenital diaphragm and effectively starts the penis. And then the spongy urethra is the elongated portion. And you can see collectively inch, 6, X number of inches, a lot of variation, of course. It's part of it. We saw those before. A lot of reasons for UTIs. We talk about that in micro. And again, it's more about the length than anything, sexual activity, rather substantial. Most of these are not, and we look again in micro at these, are not classic STDs that would generate more concern. When you say a typical UTI, they're eminently treatable with antibiotics or other agents, if they're yeast infections, etc., things along those lines. The problem is if they are not identified and treated promptly and efficiently, then you have additional problems. And again, I say it 1,000 times, just like the ultimately it's a plumbing problem. If it can't go out, it goes up. When it backs up, now you have problems. So, and there's different names. Urethritis applies that. Cystitis is bladder. Urethritis is urethra. Getting into the kidneys, much worse. And all of these, this is standard for sexually and non-sexually transmitted infections. Painful dysuria, sort of a global term, not right. Urgency, frequency, discoloration. The higher up it gets, the more back pain is involved. And thankfully, we have a lot of antibiotics available to it. And then this is just the nugget about urination. I don't bother with that for here. Incontinence, etc. I don't bother with that here. There's a lot of problems with that. The big problem in the hospital for years, I don't know how it differs. I haven't had a practice that was not hospital-based, but utilized the hospital since 2000. Last time I operated was the end of the calendar year 2000. So I don't have enough to tell you what's common in the hospitals now. I don't. And that ends that. Brief introduction for male and repro, and see it. Like I said, I'll find out about the specimen after we're done here. I'll see if I can interrupt who's ever up there. Which I'll do anyway. One freaking chuckle. Oh. One smile. What did I do? I'd go home and complain about this. And my wife would certainly be in console me. She would look at me and go, just suck it up. I can tell you that now. But I've had a day. Nobody cares, Lou. Okay. 26A is male, 26B is female. This is the common part. Just like we had the kidneys and everything else with the urinary tract, when you deal with these systems, you have primary organs and you have accessory organs. The only primary ones are the eggs, are the ovum and the testes, where the eggs are made and where the sperm are made. Anything else, any tubular structure, any glandular structure, be it male or female, are accessory organs. So whether it's prostate or seminal glands, whether it's the uterus or the vagina or the oviducts, whether it's the vas deferens or the epididymis, it doesn't matter. The only primary organs are where the eggs and sperm are made, respectively, ovary and testes. Okay, and that's their job. They are a double duty organ. They have both exocrine and endocrine function. Exocrine, you might remember, they use tubes or passageways for the eggs and the sperm to get where they're supposed to go. The flip side of that, the endocrine function, is they make, whether it's testosterone or estrogen or progesterone, those are endocrine There's blood vessels around them, capillary networks that suck that up. They're able to go. So what is with the whole idea? Intercourse. The frame to understand these systems are about what the goal of the exercise is, ostensibly. Okay, this is not necessarily a course, it's an anatomy and physiology course. So the way to understand any of those systems is more about what they're supposed to do and what happens if they go right. Okay, and in that case, intercourse, fertilization, implantation, birth. We don't get into all of that here, okay, in our particular course. We do the anatomy and physiology, male and female. You may have other courses for growth and development or aging or things like that. To me, it's in a different sphere. Okay. So you're producing haploid cells, eggs and sperm. And I mean, I don't go crazy about the meiosis things and polar bodies and all that microscopics. I'm not going to do it. I mean, I'll let you understand it as best I can without going crazy. I don't think it's really necessary. Okay. But the whole idea is they form, when it's fertilized, we form something called a zygote where they fuse, and that effectively creates the complete number of chromosomes because they're both haploid 23 and 23. Now we have 46. In this case, 23 pairs of chromosomes. That's a zygote. And then, assuming the process goes, if you will, the way it's supposed to, if you want to think of it that way, it makes its way eventually into the uterus for the fertilization occurs typically in the tubes, the implantation occurs in the uterus, and so development, that would be gestation, and if the baby is born, hopefully, or successfully, parturition. And so you'll see grava and para in the old days in the medical chart. Grava would be how many times they were pregnant, para would be how many times they delivered a baby. Whether the baby was alive or stillborn or not the issue. Okay? My frame for this a lot is the commonality. How close these two systems are in physical appearance, though it doesn't appear that way necessarily, but they are. There are just some significant differences. But when you see it sort of stripped away, you can see that there's a fair amount of similarities as well. We all genetically, you probably know this, we all start, the male gene, which I think is SXY, doesn't begin to demonstrate itself until about the 5th or 6th week of gestation. So that's when the male components start to get the trigger to develop appropriately. Okay, so common origin during development, that's why we see, they call them homologous, I call them analogous structures, clitoris and penis, okay, analogous structures. Vas or ductus deferens and oviducts or fallopian tubes, similar structures. Testes and ovaries, certainly they're analogous because they do basically the same thing. Exocrine and endocrine function, producing the haploid cells, be they eggs or sperm. Different. Okay, so all of those are, and I comment on those, and something you should keep in mind. Okay, so the primary gonads, testes and ovaries, egg and sperm production, process is known as meiosis. Mitosis is all about making identical cells. Meiosis is all about diverse cells. Everything has got to be different. Okay. My wife has 5 children. You can tell they're brother and sisters. None of them look the same. Similar, yeah, not the same. It's not that difficult to tell those kinds of things. My sister and I couldn't look any more different. She weighs the same she did in high school. I want to kill her. Sorry. She and her husband, they've been married for almost 60 years. They weigh the same. I demand a recount. Didn't I tell you that about her? I wished her happy birthday. I told you that story. October 9th. Happy birthday. Have a great day. 78 years old. Oh, we are having a great day. We're in Spain. We're in Madrid. Well, enjoy the tapas. Oh, I'm texting you from a tapas bar. Just spit. Oh, thanks. The wind chills were 9 yesterday morning when I walked the dog. Okay. So, and we'll get into the role of the sex hormones or steroid sex hormones, testosterone and estrogen, and everything else are accessories. This is the big player in both. We looked at it a little bit in endocrine. It has to do, everything is based on circulating levels of estrogen, progesterone, and testosterone. When those levels begin to fall, what keeps them in balance, so they always, so during the years, and we're talking about the childbearing years for women, and for a substantial amount of years for men, there's some alterations, probably starting around early teens and then peaking and saying somewhat stabilized well into 60 or 70s and even longer. Okay. It's all about this, the hypothalamic pituitary gonadal axis. Okay. They have a little cute little name for it. And what it does is it measures those hormones in the bloodstream. And if they begin to get too high, too low rather, they start to generate this from the hypothalamus, the posterior pituitary. GnRH stands for gonadotropin release hormone. It tells the pituitary to do, release hormones are uptick controllers. It says release follicle stimulating hormone, luteinizing hormone, and also something called prolactin that you might remember from endocrine. FSH, when it says follicle, it means make eggs and sperm. Luteinizing means make the hormones, testosterone, estrogen, and progesterone. And so it's classic homeostasis. When the levels rise up, this stops being active, slows down. So it's tiny little upticks and downticks. And for most of our lives, the great vast majority of our lives, they're active. So that's the big player that does the things that it does. So, and then once they're released, and we know basically what they do, they maintain quote unquote reproductive health that are there. So there, and even when levels get high, then this substance called inhibin is released, and that has somewhat of a negative feedback effect on follicle stimulating hormone. It's interesting the whole world. When we get into the female, we explore a little bit more about, because it's the odd thing of when at certain times we see positive feedback in female repro probably more than any other place except blood clotting. It's really interesting in that regard, and they're showing it to you. So at puberty, and this is the nugget about that, okay, when the reproductive organs grow to adult size and start to become functional, and you can argue back and forth. Most of us feel it's coming a little bit earlier. There's a lot of speculation involved, a lot of use of growth hormones in foods that we use. That's been, I hate to use the term adulteration. It's the whole idea of GMO and things like that. Is being able to, in the foods and that we consume. I mean, there's we think that antibiotics have played a role with early exposure, with allergies, impact on antibiotics. There's a lot of theories, and I think there's probably a lot of truth to it. I'm not sure, I'm no expert to comment on it, but it looks like it's getting earlier. So before puberty, low levels of steroidal sex hormones are enough. As it approaches, for whatever reason, that hypothalamus is not, it takes bigger numbers to inhibit it, so it's not very sensitive, and all of a sudden, at whatever that time is, based on a number of factors, it starts to release GnRH, and that's effectively when puberty starts. Okay, so the follicle stimulating and luteinizing is released. They release more sex hormones. It continues to rise the threshold. Okay, so the threshold for inhibition, when they talk about a pulse-like manner, it really comes on very rapidly until finally the adult pattern is achieved. And at that point, the reproductive system becomes more or less mature and active. That's the best way to describe it. I don't do the meiosis number. If you go back and look, we probably covered a little bit of it in AP1. or in other classes, the whole idea of mitosis, again, is exact duplicates. We double the DNA, we double the number of cells, a lot of safeguards, the whole cell cycle to make sure. This is the opposite. So in meiosis, we're doing effectively a reduction division. In the male, we're making for one cell, we're making 4 genetically diverse eventual end products we call sperm cells. In the female, you're all born with these cells already ready but suspended in the meiotic process. They're suspended in something called prophase 1. So theoretically, even though there's some, not controversy, there's some suspicion that there are some additional ones being made as we learn more about the body scientifically. And men, they don't start to be formed until puberty. So it's a different, and that's significant as well. So at that point, they begin meiosis in women. Effectively, one egg is basically chosen. How that occurs, don't know. Typically on one side, then the other side, and then that matures and undergoes these meiotic divisions. So it reduces the number of chromosomes without doubling it. And so it's first they reduce by half, then they're reduced by half again. So theoretically, the chosen egg would make 4 eventual eggs, the chosen, what they call follicle. It doesn't work that way because it forms them irregularly, and so effectively one leads to one final product. And we get into all of these things involving the terminology, and we may or may not have done it, but this is what accounts for the genetic diversity. There's a point early in, if you remember, prophase and PMAT, prophase, metaphase, anaphase, telophase. Early in what's called prophase 1, these 4 chromosomes are close together. The 2 that are, these are sisters, these are sisters. The 2 that are not in the middle, a lot of times, based on the centromere, will cross over here. It's called chiasmata, crossing over, synapsis, genetic recombination. They'll have different words. And what happens, they can flip-flop little pieces without hurting them. Okay, and then later on, we might remember the law of independent assortment. Those 23 chromosomes don't all light up. It's not like a line where everybody's facing forward. You might have 2 facing forward, 1 backward, 3 more forward, 3 more backward. It's independent assortment. So form a line, and it's like, it's like one of those, it'll be right out of Spaceballs. The movie, not the lunchbox or the flamethrower. Okay, and so that is where the diversity comes from. So we have different traits and things like that. And so we'll take a look at that very, very briefly as well. That's probably enough of me blabbing for you today. So I'll blab more about this on Tuesday. I will let you know shortly. So look for an email from me.